This is the case of a 25-year-old patient with recurrent knee pain. On initial radiographs, nothing was seen and patient was sent home. Patient came back with persistent pain and a CT scan was obtained. Axial and coronal reconstructions of the knee show basically no bone destruction. There is no evidence of any articular abnormality. In retrospect, we can see a region of increased sclerosis at the distal lateral metaphysis and epiphysis of the femur. An MRI was obtained. We have T1, T2 fat suppressed, and T1 fat sat postganglionic images. It is obvious in MRI that we have a very well demarcated lesion within the distal lateral, femoral metaphysis, and epiphysis. It crosses the growth plate. It shows mostly low T1 signal intensity, high T2 signal intensity, and enhancement. Please note that there is no trabecular destruction. Also, there is no periarticular edema or enhancement. This lesion does not extend into the articulation. This is a very characteristic finding for primary lymphoma of the bone, a lesion which is occult on radiographs because it does not destroy the trabecula. More like a malleable lesion, as you would see in the kidney, that it would enlarge the size of the kidney without deforming it. Please note that primary lymphoma of the bone usually shows a cellulitic lesion at the end of the bone, usually metaphysis and epiphysis, and is associated to periosteal reaction. It also can show a moth-eaten pattern. But when it shows a lesion like this that you can see very well on MRI without trabecular destruction, you should think about primary lymphoma first. That is not the classic appearance. Also remember that secondary lymphoma is more common than primary lymphoma, and at the end of the day, lymphoma can look like anything.